Here's Dr. Scott Schachter from the Ocular Surface Academy with your industry spotlight.
Dr. Robert Herrick co-founded Lacrimedics in 1983. As a licensed board-certified ophthalmologist, he continues to specialize in the treatment of corneal and external eye diseases and related oculoplastic procedures to reduce surface evaporation. The medical opinions he expresses in this industry spotlight are strictly his own.
So welcome everybody today to another industry spotlight. Today we're lucky enough to have Dr. Robert Herrick of Lacrimedics, and I had the pleasure of meeting Dr. Herrick probably in the early 1990s. I believe it was at a Vision Expo and all the way back in Anaheim, and I learned a lot about punctal occlusion at that point. And I've certainly throughout my career utilized punctal occlusion quite a bit. So it's a pleasure to have you today, Dr. Herrick. We were talking earlier about how you got interested in ocular surface disease, and I understand for you this happened at a very early age. Why don't you tell us your story?
Well, actually, it goes way back. See, I'm a senior citizen, 85 years old now, and way back in 1944, my eyes got red and irritated. My parents took me to doctors, and they said I had an allergy. But they didn't explain why my left eye was more allergic than my right. So even at that age, it didn't quite pass the logic test. Then following that, I went to a doctor up in Durango, Colorado, and he used 13 beta radiation treatments on my eyes trying to get rid of the red. So at age 15, I decided I would have to go to medical school. And that wasn't easy because New Mexico, where I grew up, did not have a medical school. And those were back in the days when it was hard to get in. But I studied real hard and got into the University of Oklahoma in 3 years instead of 4. Then after I finished my medical school years, I did an internship in Tulsa. And then I came back to New Mexico and took 2 years of general surgery. That was very important because I learned a lot about how the body responds to surgical procedures. I went into practice with my father in New Mexico for 6 years. He finished medical school at age 54.
Wow.
He went back to school at age 50, and he was an English teacher. So then after those 6 years, I picked up a residency out in California at Hollywood Presbyterian Medical Center. So I came out there and took 3 years of general ophthalmology residency, and got a reputation for hard work, and picked up an extra 3 years of fellowships, one in cornea with Dr. Tony Nesburn, and 2 years with Dr. Bernice Brown, ophthalmic plastics. So then I was ready to start practice. I opened my office there at Hollywood Presbyterian in 1977 and started seeing very serious cases of dry eye, and started doing some occlusion without any pre-testing.
Was there an epiphany you had somewhere along the way that made you think I should be plugging up a tear duct to increase the moisture in the eye? What led you to that? Was there a moment where you realized this eye needs more fluid, I've got to plug up the drain?
In real severe cases, it was not a big decision without even any testing. But in 1979, I had a patient from San Luis Obispo who was referred to me with a corneal ulcer. And so he had a lot of roughness of his cornea, obvious dryness of the eye. And I got ready to close his tear duct, but somebody had opened up his lower tear drain trying to get rid of all the reflex tearing, which actually caused the ulcer. And I thought, oh my goodness, I can't close it. I'll have to stitch it up. So I stitched up with nano nylon sutures, and within 4 days the ulcer healed and the roughness went away. But with that experience, I thought I could be doing this stitch test on people to see if they would improve before I actually did any treatment. So that was the beginning. So as I did that, then the patients started educating me about how there are different changes in their physiology.
Do you remember that first patient reaction when you took this severe dry eye patient and increased hydration to the eye? Apparently, you said they had clinically looked much, much better. How were they symptomatically?
Well, that was the interesting thing about it is not only did they report to me about how their eyes were better, they stopped itching and tearing, quit tearing, reflex tears, but they also reported a whole bunch of other symptoms. For example, one of the great changes was in the nose. Their sinuses would clear and they could breathe freely through their nose. Their hay fever went away. When their eyes quit itching, their nose cleared up, then their hay fever went away. The patients actually educated me about all these other changes in the body. And
that's interesting you mentioned that, because once in a while I'll certainly put plugs in for a patient on glaucoma medications to see if we can get the pressure to drop a little bit more and keep the drops out of the body. And I've had some success with that. So what do you feel is the primary cause of dry eye and related ocular surface disease?
Well, actually, the thing I was very impressed with was Dr. Marshall Doan, PhD's work, who he reported in 1981 about the lacrimal excretory system. He took a camera that would take 500 pictures a second and studied the lacrimal excretory system and found out that it was typically 10, even 20 times too active, pump the eye dry. That to me was a very important study. It supported what I had been finding clinically, but of course, with occlusion testing and therapy, it saves all three layers of the tear: the mucus, the aqueous, and the meibomian layer, oily layer. So I think it helps all three.
Yeah, well, very interesting. You've been around for, of course, a lot of history of dry eye. And in addition to that, Dr. David Sullivan as well. We spoke to him not too long ago, and I was amazed at his depth of knowledge and the length of time he's been involved with dry eye. Tell me about your experience with TFOS and Dr. David Sullivan.
Well, I became acquainted with Dr. Sullivan and TFOS, I think it was 1993 at the first Bermuda meeting. I was there and I presented after Dr. Limp. He presented the importance of objective evidence. And of course, his thoughts about all that led to the development of the osmolarity tear lab apparatus, originally developed by Dr. Gilbert. But after Dr. Limp presented, I got up and I said, I certainly agree we need these good objective studies. However, clinically, I want to present a different approach, the subjective approach. I had developed the collagen implants after finding out that middle ears would clear in adults. I thought I need something to use to test children that doesn't require an anesthetic injection. So I developed the collagen implants. And at that meeting, I presented how we could use a symptoms checklist and then put the collagen implants in, and it had such a rapid response. Typically in 5 minutes to 30 minutes, patients would get rather dramatically better. And we could depend on that to realize that lacrimal occlusion, permanent type treatments, were going to really benefit the patient.
You developed intracanalicular Herrick plugs in around 1989 to overcome some of the drawbacks of punctal plugs or surface punctal plugs. And I certainly know in my own practice, I avoid surface plugs because I see them often caked in mascara. We'll have pyogenic granuloma form on top of them. They can cause distension of the puncta if we need to remove them. There certainly are drawbacks. And how has Herrick evolved in terms of intracanalicular plugs and the approach over the years?
Well, we found out that the intracanalicular plug turned out to be treatment of choice for upper lid only. Lower lid, there's too much debris and so forth going through the lower system that there was too high of an incidence of a granuloma forming within the canaliculus. But in upper lids, that just didn't seem to happen at all. So that's been a very important product to use in the upper lid, the intracanalicular plug that's can be visualized with transillumination. Even especially now, I'm finding out that children, with the middle ear trouble and the hay fever and asthma and chronic bronchitis, and even in infants, As I see patients, I tend to educate the patients all about the dry eye. And so I had this one lady, I educated her, then later she adopted a newborn. But little Andrew had trouble breathing through his nose. He was always breathing through his mouth. And she took him to a couple other doctors and they weren't getting anywhere, but she learned enough. She brought him to me and asked me to do the collagen test on little Andrew at age 10 months. So I did that, and within 30 minutes, little Andrew could breathe through his nose fine.
Wow.
So based on that, I put the smallest silicone plug in his upper lid. Then I didn't hear from him for over a year. They lived in Northern California. And she called and said, no, little Andrew had been just done great for the whole year. She'd only had him back to see the doctors once. That was kind of a real eye-opener, that if we could educate the family physicians and pediatricians that children, infants that have trouble breathing through their nose were referred in and had the collagen test and got better, then we could prevent SIDS, which is the greatest cause of death in the first year of life.
Very interesting. And you mentioned upper plugs. When the puncta meet, is there a vacuum that occurs? Do they meet when you blink?
Well, in the old days, there were a lot of theories that were developed that with time didn't seem to matter. For example, people named different valves inside of the canaliculus that was supposed to keep from being active while preventing backflush and so forth. But the thing that Dr. Doan's work did, it showed that while the eye was open, there was very active siphoning of the tear off the surface of the eye. And it turned out that the upper lid was siphoning off the fresh tear that had never been blinked on the eye before it ever had a chance to be blinked on the eye. And that's the reason why ultimately we realized that the upper lid was more critical than the lower lid against what was being generally taught.
And yet that's still your belief that clinicians should really begin with the upper puncta?
Yes. My associate, Dr. Sanchez, was the first one to mention that, and we studied it. And then with Dr. Doan's work and so forth, it became very obvious that we improved not only the quantity of the tear, but the quality by treating upper lids first.
We talked earlier about how the upper puncta are really important to occlude first. What is the exact mechanism of a blink when the lid comes together, the puncta meet, or do they not meet? How does that work?
Well, Dr. Doan in his camera work showed that with the blink, the two puncta tend to come together, and for a split second, you have a closed system. So it actively pumps into the nose. But then when the eyes open back up, the lacrimal excretory system continues to siphon off fresh tears while the eyes open.
So breaking that potential siphon by plugging the upper puncta played a big role.
Well, that lets the tear move laterally so you don't have lateral dry eye. It means more lubrication medially so that you don't develop pinguecula, either lateral or medial. And the medial pterygium, which is in severe dry eye, is the body's effort to try to vascularize the tissue to prevent ulceration. So instead of being caused with the sun, if it were the sun, the outside of the eye would get more sun than the inside. We see mostly pterygiums lateral, but we see them mainly medial because that's the closest to the pump.
Very good. And in 2003, your company developed dissolvable plugs. I'm a big fan of dissolvable plugs. And tell me a little bit about the inspiration for that and what have you developed since then?
Well, when we saw some problems with intracanalicular lower plugs, we realized we needed some way for that system to clear out occasionally. So with the 6-month plug, that's the ideal plug for the lower lid. It blocks about 90%. And it gradually dissolves and then has to be replaced. But at least then we've seen no tendency to get infections in the lower canaliculus anymore with that product. So ideally, the upper lid does very well with the silicone intracanalicular plug, and the lower lid does well with the 6-month dissolvable.
And tell me a little bit about your new ComfortTip and the AccuFlo Punctal Plugs.
Dr. Jerry Freeman was the first one to come out with a punctum plug, but there was a 40% loss rate with that plug. And then if you replaced it, then there was a 60% loss rate, and it tended to irritate the eye. So that was my motivation for designing the intracanalicular plug in the first place. So we have since gone back and tried to make some improvements on surface plugs, since some doctors feel more comfortable when they can continue to see the plug after they insert it. But with time, and as doctors become more involved with lacrimal occlusion, they develop a lot more conviction about how important it is. So lacrimology, this new specialty called lacrimology, should become one of the biggest specialties in healthcare, and should involve ophthalmologists. We certainly need the whole team of optometry. I wish we had some fellowships, even a 2-year residency in lacrimology someday, and that optometry could become one of the main practices of lacrimology.
Well, we certainly see an explosion of prevalence in dry eye disease, digital device use playing some role, medications, pandemic driving a lot more across all age groups. And to that point, how do you feel the lacrimal system dysfunction impacts overall health?
Well, what I think happens is, see, in medicine, they've come to realize that the great big cause of the diseases of later life, namely cancer, vascular disease, diabetes, and chronic respiratory, are all caused by chronic inflammation. So it turns out that the surface of the eyes are the only surface of our body that has to stay constantly moist, and as such, they're the most sensitive tissues of the body. And with that lacrimal excretory hyperactivity and the eyes being irritated, the brain gets this message and turns on healing mechanisms, namely the inflammatory response, the increased in the thickness of the respiratory mucus to try to save the tear, and then gradual thickening of billions of basement membranes throughout the body, which ultimately interferes with the function of the tissues. I think that we will find that dry eye is one of the great triggering mechanisms for chronic inflammation. And so when we shut that down, we stop the dysautonomia, overstimulation of the vagus nerve.
And what do you think is an appropriate age to consider lacrimal occlusion, punctal occlusion?
6 months.
Interesting. Why so young?
Well, because the greatest cause of death in the first year of life is SIDS. And if the infants don't have thick mucus, they don't suffocate. So they can breathe through their nose and not suffocate. So we need to teach the pediatricians and family physicians and so forth to refer these patients so they can have the collagen test, the Herrick test, and see if they improve, which they will, very dramatically, and then place the silicone plug in the upper lid, the smallest silicone plug, and prevent that first year of death.
Very interesting.
So take all the sicknesses in childhood, namely middle ear disease. How I found out about middle ear disease, my grandmother lived with me in South Pasadena when she was 95, and one of her babysitters came over one night to be paid, and she was telling me all the trouble she had with her ears. This was 1982, and she had been down to the house group and had a tube put in her ear and so forth, but she'd never known her left ear not to drain purulent material all her life, age 35. And so after she told me this story and I was a good listener, I said to her, well, Debbie, what about your nose? And she said, well, it's all stopped up. I said, what about your eyes? And she said, well, they itch. And all of a sudden I had this tremendous compulsion to want to do the stitch test there at home. And I had missionary supplies at home. So that night we propped up against the dining room table. My mother held a mirror to shining light so I could see better. I put a stitch in her lower lids. And the next day I called her and she said, my nose is clear and my eyes don't itch. And I think my ear's better. I said, you need to come down to the office. I had the office at Hollywood Presbyterian those days. So she came down to the office and I could not see the eardrum, but she was really happy. And at that point, I had invented a laser treatment to close tear ducts. So I closed her lower lids with the laser. And I saw her back in 10 days. And then I was shocked. I looked in this ear. I could totally see the drum. I could see the hole in the drum. All the purulence was gone. But having spent those 6 years in general practice, I thought, well, children are the ones that have all this trouble. They're not going to let me do the stitch. So that's whenever I came up with the collagen. So you take the disease of childhood, the SIDS, asthma, pneumonia, chronic cough and bronchitis, and then you extend that on into adult life, all the causes of death. About 2/3 of the causes of death are related to chronic inflammation or that congestion. And for example, for the coronavirus here, I put out an 11-page paper, I think it's on LinkedIn, describing aggressive steps to take to prevent death from the pneumonia of coronavirus. And when the president had that coronavirus infection, I sent a copy to his physician. I think it's very critical. I think lacrimology, though doctors that are getting involved in lacrimology are going to have a wonderful opportunity to participate in prevention and cure instead of treating symptoms and complications.
You talk about an important point about keeping things out of the rest of the body by plugging up the tear ducts. Share a little bit. I mentioned earlier, sometimes for patients, I'll use punctal plugs to actually increase retention time in the eye of topical ocular medications. Is there any research in that arena?
Yes, there is. There are good studies showing that makes the glaucoma medicines more effective. For example, Lacrimedics can furnish references for those papers. And Gilbert and Wilhelmus printed up in Cornea magazine back in the 1990s a wonderful study that showed that with Pseudomonas infection, if they put tobramycin on the eye without collagen, it would decrease the count of the Pseudomonas to about from 2,500 units down to about 1,200. But if they put the collagen plugs in and put the single drop on the eye, within 2 hours, it dropped down to under 200. So a single drop practically wiped out the infection. That's a very interesting study to look up by Gilbert and Wilhelmus in Cornea magazine.
Well, you bring up another good point, the support that Lacrimedics can provide. And I recall very well early on, 68761 has become a code that's imprinted in my brain forever. And you helped me along the way in terms of how to bill, some of the forms, some of the informed consent. So Lacrimedics is a huge resource to help doctors either get started in the world of punctal occlusion or up their game a little bit more. How can people find out more about Lacrimedics?
They can actually call them on an 800 number, 1-800-4TEAR. Or they can they can go on the internet to lacrimedics.com.
Lacrimedics.com. Okay. And your website also has some resources. Is that correct?
Right. And of course, they can order products if they need products to work with through Lacrimedics there.
Very good. Well, I sincerely appreciate your time today, Dr. Herrick. It's wonderful to hear the history. My own daughter is actually a general surgery resident currently in Tennessee, and I know she's going through it. So I have a lot of respect for what you went through to get where you are. And you've contributed so much to the world of dry eye disease over the years. So thank you again for joining us today. And remember, take a look at lacrimedics.com if you have any other questions. Thank you again, Dr. Herrick.
Surely. Good day.
This has been your Industry Spotlight with Dr. Scott Schechter. Thanks for listening. You can find us online at www.ocularsurfaceacademy.com, all major podcast platforms, and YouTube.